Good afternoon, everyone. I'm Jennifer Williams, and I'm so happy to be here with you today. It's Colorectal Cancer Awareness Month, and we have two great doctors here with us today to discuss everything you need to know about colorectal cancer. So please help me welcome colorectal surgeon, one of my favorite guys, Dr. Mark Gilder, and medical oncologist, Sirish Dharmapuri. If you have a question for either doctor, please leave us a comment below, and please help me welcome Dr. Dharmapuri, Dr. Gilder. How's it going today?
Good, how are you?
Excellent.
We're so glad to have you.
Thank you for having me.
It's so nice to have kind of both sides of the scale here for colorectal surgery. Yeah, colorectal surgery, medical oncologist. And it's Colorectal Cancer Awareness Month, as we said, so make sure, and we will tell you a lot, make sure you schedule those colonoscopies because they're so important. They can save your life. So let's just jump right in. Why don't you both tell us a little bit about the work you do here at CBMC?
I can start. My name is Sirish Dharmapuri. Like you said, I am a gastrointestinal medical oncologist. I specialize in treating cancers of the GI tract, all the way from the esophagus down to the rectum and the anus. I also specialize in something called a hepatic arterial infusion pump, which is a technique where we give chemotherapy directly into the liver. On top of that, I also run clinical trials actively in the GI space.
It's amazing. Dr. Gilder?
I am a colorectal surgeon. I'm kind of a combination of a general surgeon and a gastroenterologist. My specialty deals with the diseases of the colon and rectum. Colorectal cancer and anal cancer, that's all part of what we focus on and how we treat. Our goal also is to try to prevent this disease from happening. We work along with gastroenterologists, medical oncologists, radiation oncologists, pathologists, and this is part of the team that would help take care of you if in fact a disease like colorectal cancer were to develop.
And let's just jump right on that. Dr. Dharmapuri, what is colorectal cancer?
Okay, let's start with understanding what a cancer is first. This is really just an unregulated, dysregulated, excessive growth of abnormal cells that can affect really any part of your body. It is generally driven by mutations that people acquire due to various insults over their lifetime. When these cells grow in a dysregulated fashion, they also acquire the capacity to move to different organs. And when this phenomenon affects the colon, we call it colorectal cancer. There is a distinction between a colon cancer and a rectal cancer in terms of the anatomy of these two specific organs. The rectum is essentially the last 15 centimeters of the colon. They differ, they're identical in their biology, but they differ in the way we treat them. Mm-hmm. So it's a very important distinction to remember.
Can I ask you, when talking about colonoscopies, we often hear the word, they're looking for detecting, I can't talk today, everybody, I apologize. Detecting polyps. What is a polyp? What does that mean, that word?
Yeah. Polyps are also abnormal cell growths or tissue growths that project from the inner lining of the colon into the lumen of the colon. A polyp is different from a cancer in the way it behaves and the mutations it actually has in it. They can be benign polyps, but also the more concerning part is that some polyps can be precancerous.
And, did you want to add? I'm sorry.
There is also a time that there is a transformation where there's a sequence of events that takes place where you have a benign polyp that can become a malignant polyp. And that is where we can act before that transformation fully takes place, where you have the development into a malignant polyp or colorectal cancer. The most aggressive way that we can take care of that without surgery is by doing colonoscopy. We could diagnose and become therapeutic and treat at that time. And by preventing the transformation into cancer, that's really where we can be very effective, very efficient, and also learn a lot more about how we can take care of somebody for the future. We also can use this information and with genetic analysis help protect other families if we recognize this in some type of family genome.
Are there specific causes of colorectal cancer? Is it preventable?
Well, break it up into, I'll say, environmental and genetic. Mm-hmm. The genetic issues with colorectal cancer you cannot change. I mean, we come from our parents, and that's why it's so important to know family history. Mm-hmm. So leave that as it is, but knowing your family history is really important because now we have tests that we could determine preoperatively if you are at higher risk. There is, for instance, a Ashkenazi gene that we can look at. There are also genes and there are also conditions there where we can genetically evaluate an individual who was totally unsuspected, and that is in a condition called Lynch, or hereditary non-polyposis colorectal cancer. There is also a condition called familial adenomatous polyposis, and if that is discovered in one individual, we then have to look in other first-degree family members. So this is a way that we could do this before we even act accordingly in doing colonoscopy.
And Dr. Dharmapuri, how common is colorectal cancer?
Unfortunately, it's very common to see colorectal cancers in the United States. We recognize colorectal cancer as actually a large public health hazard these days. It is the third most common cancer in the United States, and it is the second leading cause of cancer deaths in the US. We see approximately 150,000 cases every year, new cases every year, and about 50,000 people die from colorectal cancer every year. So yeah, huge public health hazard. Thankfully, over the last couple of decades, we've seen a decline in the overall incidence of colorectal cancers in the older population, and that is attributable to colonoscopies and the very stringent screening programs we now have available in the US. On the other hand, and very scary contrast on the other hand, is a huge dramatic increase in the incidence of colorectal cancers in the age group between 18 to 50 years of age. Particularly looking at age groups 20 to 29, there has been a dramatic increase in the incidence of colorectal cancers. We've seen a 50% increase in the incidence in this age group in the last 3 decades, and every year there's been a 2% increase in the incidence in this specific age group. And the scientific community recognizes that this is a public health hazard, and there's research going on to figure out why this is happening. We don't have we can't pinpoint a specific reason as to why this is happening, but we suspect this has got to do with the Western diet, and we'll hopefully have answers in the next couple of years. But yeah, alarming increase.
What I didn't talk about was some of the environmental issues, and that you can also factor into nutrition. In other words, obesity is certainly an increased risk for colorectal cancer, along with excessive alcohol, smoking, and inactivity or lack of exercise. Those are the types of environmental conditions that we believe can be contributing to a higher risk of colorectal cancer, especially also in the younger age group.
And we've talked about this before, and especially a lot during this month, the age of getting a colonoscopy has been lowered. So can you tell us again, just drive home for us, like the importance of those colorectal screenings, who should be getting them, at what age can we start?
Well, what we've recognized, at least in my lifetime also, is that we have lowered the age of recommended colonoscopic evaluation. We started above the age of 50, then we went to 50, now we're down to 45. That is a recognized benefit where screenings have been shown to help prevent colorectal cancer, and at the same time begin that type of evaluation. If nothing is found in an individual who has no family history or no risk, we believe that evaluating an individual 10 years later would be the next step. Now, if you have a family history of colorectal cancer and a first-degree relative, like a mother, a father, or a sibling, that is a completely different story. That's not what we would do.
And I'm going to say it, I'm going to put that, and we're going to pin that link in there, colorectal screening, rwjbh.org/colon-screening. So we'll put that in the comments for you. It's very easy to make an appointment. If you are 45, older, of course, always consult with your doctor. So Dr. Dharmapuri, if you are diagnosed with colorectal cancer, what are some treatment options?
How much time do you have? So I think it's a very broad topic to discuss, but I'm going to summarize it as short as I can. So let's talk about colon cancers first. If we first find a cancer in your colon, the first thing we would do is to get a CT scan of your body to make sure that the cancer has not spread outside the colon. And then Dr. Gilder would take you to the OR to remove the part of the colon that has the cancer in it. Then the pathologist analyzes the tissue to tell us the extent of the disease, the number of lymph nodes involved, various other things that they tell us, which determine who benefits from chemotherapy in the post-operative setting versus who does not. And that is the role of chemotherapy in this setting is to kind of decrease the risk of your cancer coming back. We're learning every day that there's better tests to figure out who benefits from it and who does not. But as of right now, we use the pathologist's information to determine who benefits from chemotherapy versus who does not. But if you have an early stage rectal cancer, it's a combination of chemotherapy, radiation, and surgery. And it's usually a multimodality approach, and we usually sit down and discuss how each of our patients should be treated because every individual is very different. And these are for basically localized cancers. But if you have stage 4 cancer of the colon or the rectum, you are still considered curable as long as you have limited disease affecting a single organ. And that usually, again, is a combination of chemotherapy, hepatic arterial infusion pumps, surgery, plus or minus radiation. And even if you are not curable, if you have a disease that is something we cannot treat with surgery or radiation, you can still prolong life in the order of years at this point with a combination of chemotherapies, immunotherapies, depending upon the subset of your cancer, and targeted therapies.
And we have a fantastic multidisciplinary team here at Cooperman Barnabas, and there's so many great doctors and treatment plans and support staff to help. And Dr. Gilder, I know these are some things that you've been excited when we've talked lately. There's so many new advancements in technology. Can you tell us a little bit about some of them?
Well, part of what Sirish was talking about is a multimodal team, and that involves fellowship-trained individuals whose specific job is the treatment of cancer. And that's where we get together, where we evaluate cases and how we're best going to treat someone with the combination of therapy and management. On the other hand, minimally invasive surgery is also what we've excelled at over the past decade, where we've converted from an open surgical approach to a minimally invasive approach. That approach has even become more advanced with the benefit of robotic surgical surgery. And what we've learned and what we've sort of benefited by is what we've given to the patients. What used to cause a patient to heal for 8 weeks post-surgery, we've converted down to 2. So we use smaller incisions, yet do the exact cancer operation that's required, and at the same time get a person back on their feet, back to doing what they would normally do and getting back to their present lives.
And I know you've mentioned before, AI is kind of playing a role now in the advancement of treatment for colorectal cancer.
Yes, even now we have merged AI in our treatment modality. The perfect example is colonoscopy, where we have a artificial intelligence box that we will adapt or sort of commingle with a colonoscope. And that will allow us a better harvest of polyps. In other words, our goal is to find anything that could be theoretically precancerous. So by using AI and this technology, we increase our surveillance percentages, and at the same time, we believe do a better job. And that's also the future, because now with robotic surgery, we believe that's going to be the next step, where AI will also be working with targeting and also minimizing complications and being more efficient.
It's amazing. Go ahead.
I just want to also add that we now have the hepatic arterial infusion pump program open at Cooperman Barnabas. We are actually the only center in New Jersey that does this. It's a pretty cool technology where we insert a device into your abdomen and are able to give chemotherapy directly into the liver if you have liver predominant disease. So just want to bring that up as an advance in the recent couple of years.
And of course, all this comes with the exciting news. Our new cancer center, the Melchiorre Cancer Center, is opening in 2025. Like, we're just a few months away now, which is really wild. Everything comes together so fast. What are you most excited about? What can you tell us about the new building?
Yeah, it's a really exciting time for us here at Cooperman Barnabas. The Melchiorre Cancer Center is going to be open later in 2025, like you said. It's a swanky new building, beautiful space. It's designed in a very patient-centric manner to make your treatment very comfortable while you receive world-class care.
It's amazing, and we're excited about all of that. Okay, so if you guys are up for it, I would like to play a round of fact or fiction. So I'm going to give you some signs here. You can have that one. So you can flip it as we're ready. We get on my rapid-fire questions. Fact or fiction, there is nothing that could be done for colorectal cancer.
We're going to go with fiction.
Okay. Yep. You want to tell us a little why? We can go back and forth.
Well, there's everything that we can do for colorectal cancer. We can prevent it, we can treat it, and we can cure you from it. So I'm going to nail it in that way.
Fiction. Okay. Colorectal cancer is fatal.
Is what?
Fatal.
We're going to go with fiction again.
It's very, very curable, and even if it's not curable, we can certainly buy several years of time. So fatal is very 2020.
Screening is only necessary if I have symptoms.
We're going to go with fiction again.
So many fictions.
There's a lot of fiction that we're going to have to go through.
We're debunking all the rumors.
So let's use age as at least a beginning, and that is at 45, please get evaluated. We have enough individuals within our system that can take care of you. GI physicians, colorectal surgeons. This is a simple thing that could be done. It is not a fearful procedure that you should ever be concerned about. By preparing one day in your life as far as preparing for this and undergoing this procedure, it can literally save your life. So it's simple. Just as you would take care of your car and perform a service on your car, let us do this for you and at the same time prevent something that you don't ever need.
We have that link pinned for you. It's your reminder. Okay, next one. Only people with a family history can get colon cancer.
It's a lot of fiction.
There's a lot of bad rumors out there.
Okay.
It's a fiction. Anyone? Good.
Well, only about 20 to 30% of colorectal cancers are associated with a family history or even like a predisposing genetic mutation. A majority of colorectal cancers actually are sporadic. They arise in people with no family histories. So it's far from the truth.
Okay, I have another one. I have a feeling we know the answer. Only white men can get colon cancer.
I don't think colon cancer cares what color you are.
Yeah.
And that is something that in the United States that we are desperately trying to do a better job with. I don't know if it's really something that we should even think about as far as color or race. I consider this more of an economic problem because I do believe that in economically impoverished areas, I do think that people are not necessarily getting the level of care that they should be getting. And it's unfortunate because we have the technology in which to do this properly. So I believe that if we were able to erase some of those barriers, I think that we would have a huge improvement as far as survival and prevention. And I do think that that's something that as a society we have to do a better job with.
Okay, my last one. Colonoscopies are the only way to detect colon cancer.
Also fiction.
So there's multiple other ways to detect colon cancer, but colonoscopies do remain the gold standard of how we detect these cancers. I'm not going to go into details, but I want to just remind you that colonoscopies not only detect cancer, but they are also treating precancerous polyps and preventing them from progressing to malignant lesions. So it is still the gold standard of how we do this, but there's other options. Talk to your gastroenterologist.
Now, there are different tests. There are blood tests that we can use, and there's also a Cologuard test that one can use that can test. If you have severe medical condition where you don't feel that undergoing colonoscopy is a possibility and you don't have family history, a Cologuard test is an excellent mechanism that we can use as screening. Now, there's also blood testing that is available that will detect in a very sensitive manner colorectal cancer. It is not perfect. It can give us answers, but it is not the be-all and end-all as far as screening. Possibly for the future, as this blood test is more defined and at the same time, I'll say successfully advanced, we may in the future learn that we could detect even polyps in this manner. So I do think that that's where we're going, and I do think that this is another mechanism that we can also utilize in our armamentarium. But understand that colonoscopy is not the sole mechanism.
And, I know that you're both so busy, so I appreciate you taking the time to be with us here today. Is there anything else you'd like to add?
Well, thank you for recognizing what March is. It's Colorectal Cancer Awareness Month. Understand that within our working area in New Jersey and also other regional metropolitan areas, we are available as a highly specialized and group of individuals that are well geared and well trained to take care of your specific issues. And we will provide the services that will benefit you. We will pre-diagnose, we'll diagnose, and at the same time treat you in a very superior manner. We look forward to doing that.
Yeah, I just want to say that if you're 45 and over, please get your colonoscopies. And if you're under 45, I just have to remind you the importance of listening to your body. If you notice any differences in the way your bowel movements are, or if you're seeing any bleeding in your stools, really weight loss that you can't explain, please talk to your doctor. And we should all have a very low threshold to get people in for screening.
And we're gonna, again, I'll say it one more time, rwjbh.org/colon-screening. We wanna thank you all so much for tuning in today. If you are watching this video, please, please, please get those colonoscopies, and we'll see you next time. Thank you both so much.
Thank you.
Take care.